a little bit?
It's up to you.
I think we're going to start, everybody. Welcome to the Community Health Center Board of Directors, Building an Effective Board of Directors with Genua, close?
Good.
Sorry, forgive me. McDaniel, she's the Deputy Director of the Health Center Association of Nebraska. Is that right?
Mm-hmm.
And she's a graduate of the Community Health Center Executive Management Fellowship with the University of Kansas. She holds 2 bachelor's degrees, one in health education promotion from Brock University in St. Catharines, Ontario, Canada. And, I guess it's health education and promotion. Are those the 2 degrees?
Mm-hmm.
Okay. Her background includes being an executive director of a community clinic in Bullhead City, Arizona, which became an FQHC lookalike within a year. She began her career as a health educator, leaving her native Canada for rural FQHC in Missouri. Did you meet Celine Dion while you were there?
I did. I sang with her, too.
If you can include that somewhere in there, people would really find that riveting. Her work in spearheading the Health Disparities Collaborative led her to being a national speaker at HRSA's Rural Health Association. She is also a Bureau of Primary Health Care HRSA grant reviewer, so be very nice to her, laugh at her jokes, and MSCG consultant. That's the group that handles the reviewers, and she is bilingual in Italian, so half of the session will be in English and half will be in Italian. Ready?
Excellent.
Okay. Oh, and she's asked to ask questions to her.
Great. Well, I know this is the last session and we all want to get out and have a nice glass of wine at the networking session, so I'll try and be as brief as possible. So one of the reasons I guess I wanted to do this session is I am a HRSA consultant, so HRSA will be doing 450 health center site visits this year, and I've been going out and I've been seeing a lot of stuff in the federally qualified health centers, and I don't like that the health centers sometimes get blindsided. So I wanted to provide this presentation on board of directors, board training, things like that. So that way, if you do have a review, you know what is going on in your center when the consultants come. And I just didn't know, are there health centers in here, public health entities, FQHCs? Okay. Any non-FQHC, so public housing authority? Or perfect. And the interesting part is this can be adapted to health centers and non-health centers, because board of directors training, usually there's kind of the Robert's Rules of Order, so you can definitely incorporate this in whatever entity that you are in. And so I brought a couple things at the end to kind of show you of where I got some of my documentation from. And also, I also do board training, board development. So I wanted to show you a couple books that I use as a basis for like strategic planning, things like that, that will be helpful to you. And then I also would like throughout my presentation going to give you some tips of things that I have seen in the health centers that maybe you could use and incorporate or do and do not do in your health centers that will be helpful to you. So, is anyone getting a site visit this year? Oh, hello. November, okay. Where are you? California, okay. I'm not going there. And you just had one. Last week, so. Well, I'm heading to Houston in a couple weeks. I was in New Mexico 2 weeks ago, so for some reason I'm getting the southern part of the United States, so. All right, so pretty much just kind of a basic overview on the community health center movement. Isn't it kind of funny? I'm Canadian. I'm giving you guys the health center movement. So definitely in the 60s, we had that war on poverty. That's where health centers kind of came from. We know that President Obama definitely, as part of his strategic plan, really loves health centers. There's more than 1,200 health centers with 8,000 locations. And we know that we just had some new access point funding that opened up with HRSA, and hopefully in September we'll hear about hopefully 25 new access points will be awarded. So that's kind of where we're at with that. So how do we build an effective board of directors? First of all, why do we need a governing board? As a former CEO, I was always, sometimes you have boards where you're like, man, if I just didn't have a board, I could run this show, it'd be fantastic. But really, why do we need a board? Number one, it's definitely the law. We have HRSA program requirements, so we do need them. Like any business, they are a corporation, so they definitely need to govern the health center. And definitely they have links to the outside community. So really, what does it mean to govern? Number one, to define the mission, and we have to have a mission statement. So define and preserve the mission. So once we know the mission, that's what we want to make sure with our board members. Can our board members recite our mission and vision? If they can, do they understand it? That's the next question. And if they don't, we need to explain it to them and definitely commit to and also clarify the mission. And then based on our mission and vision, we want to make sure we set goals and objectives to carry out that mission. Number two, when you govern, it also means to make policy. So there's 4 areas to make policy. We're looking at personnel, finance, so QI, QA, clinical, and operations. And we also need to remember there's a difference between a policy and a procedure. So in going into a lot of health centers, I see a lot of procedures on how to do things, but what we're looking for is board-approved policies, because a policy with procedure, you carry out what the policy is. So this is very important. Number 3, you definitely want to safeguard the assets of the health center. We know that the board of directors, they have a fiduciary responsibility. They definitely govern the CEO. That's their only employee is the CEO. They have to make sure that the health center finances are going well. You look at your audit. Maybe there's some issues with the facility. So all of these things, they want to make sure that the health center is safe. They also get to select, evaluate, and support the CEO. I've been into a lot of health centers where the medical director thinks that he's the employee of the board, the COO is the employee of the board. No, we only have one for the board of directors, and that is the CEO. And so we want to make sure if, with our board, that as a CEO, you have clear and concise job descriptions. If you're being evaluated every year, you want to make sure that you're being evaluated based on the job description. And also on the goals that the board has set forth with you. And also you want to make sure that the board does not micromanage the CEO. You have to, if you can't trust your CEO, then maybe you need to rethink that individual. I'm kind of a little honest here, so I just want to throw that out there. Honesty? All right, excellent. So that's really important. Just as a side note, as a HRSA consultant, when I go in, one of the things that I look at is a CEO succession plan. So make sure you have that. It is not a program requirement. It's called a performance improvement action. So definitely, because what happens if something happens to the CEO? Who's going to run your health center? So that's something that you want to look at. Sure. Sure. I look when I go into a health center, I look to see that the CEO has had an annual evaluation. So pretty much a performance evaluation. Just as the CEO or the COO does it on their staff, you want to have the board evaluate you. So, for example, my CEO, I was a CEO for a number of years in a couple of FQHCs. So for me, it was, it was a turnaround. So pretty much, did we have provider settlement? Were providers recruitment and retention, were they stable? Based on maybe accounts receivable, accounts payable, are your providers seeing are there any doctors, mid-levels in here? No? Midwife, beautiful. Are your you're a provider? Oh, you went to, oh, excellent. I'm going to buy your drink afterwards. I was going to say, are your providers or mid-levels seeing 22 to 28 patients a day? Just throwing that out there. No one slashed my tires. So those types of things, are you assisting your providers to getting that? So that type of evaluation, maybe personal growth. Like, are you working with the board to do some type of fundraising, the capital campaign? So that type of evaluation. Some of the CEO evaluations at times are based on staff evaluation of the CEO. I don't really like that, because if you're trying to make changes as a CEO and your staff is evaluating the CEO, that doesn't look good. So those kinds of types of evaluation. Does that help?
What percentage of health centers that this is actually have
No, you're fine. Mhm. They have to do a search. And interestingly enough, HRSA now approves the CEO, and you have to submit transcripts based on your university or college education to HRSA to have that approved. Yes, that is, I think it's program requirement number 5. It's a key management staff. Mm-hmm. Because there has been an instance where a CEO said they had a university education and they did not graduate high school. So that was just kind of making sure that they are who they say they are. Yeah. Mm-hmm. Right. Right. For sure, and you do it with providers, right? So when you go to credential them, you look at their transcript, you look at CAQH or National Practitioner Database, so it's kind of getting to the same thing. The other thing to govern, you definitely want to monitor and evaluate the center and board performance. So are you meeting the mission? If you're saying you're serving the underserved or uninsured population, are you definitely seeing them? How are your clinical measures going, especially with our UDS measures or all these measures that are coming out, meaningful use, patients at our healthcare home. I think in the future we're going to be going to kind of like that payment-based methodology for per member per month. So, I mean, are we really monitoring those? The other thing is annual board self-evaluation. And it could be goals for the board. So maybe the board would like to have a session on how to read a profit and loss statement or a balance sheet, those types of goals. Maybe they want to learn more about HR or fundraising. So kind of those types of goals. And that's important that it's board goals and not health center goals. The other thing is this is always lacking when I do site visits, strategic planning. First, you need to have a needs assessment, which is very important because if you want to add services, maybe include public housing, homeless, physical therapy, acupuncture, how do you know if you don't know if your community needs it or not? Based on that, you need to have a strategic planning. So how are you going to carry it out? I have seen needs assessments and strategic planning that they've kind of expired. So anything over 3 to 5 years, essentially it's not current, especially with the new things that are happening right now in healthcare reform and ACOs and all that stuff. You definitely need to have that planning done. You want to have written goals and objectives, evaluations. So after you get your strategic planning and you have your outcomes and your goals, how well are you doing it? Does the board report out? That's really important. And then essentially, what if the board has to make some tough decisions? So let's say you have to restructure the organization and you have to let go of a provider or discontinue some type of services. How are you going to do that if you don't have that, strategic planning? It's just being prepared for the future. Yeah. Mm-hmm. Sure. I'm going to talk about a little bit more further down the road. No, you're fine. Um, um, but pretty much, sometimes you have a board that doesn't interact with their CEO. So only the executive committee or the team will interact with the CEO. So we really want to make sure that, those, sometimes when you have consumers on the board or patients, they get a little shy. They think, oh, the CEO wears a suit, I can't, interact with them. So we really want all of the members to be able to interact with the CEO and also with each other. Sometimes the only time that board members will see each other is at the board meeting. So maybe you can look at trying to plan some other functions, for the board besides a board retreat. So what is the job as a board member? There's 3 things that they need to do. Number 1, duty to care. Definitely need to be careful and prudent when making decisions. I have seen going into some health centers where there are individuals that sit on a board for their self-gain. Perhaps they're the mayor. Perhaps it's the hospital CEO. And so they're really not able to make those types of decisions based for the health center. So that definitely is very important. The duty to be loyal. We know that it's program requirement, I believe, number 19, you have to sign a conflict of interest. And also now they're starting to do a financial disclosure form. So you want to make sure that you are loyal to your health center. Once you sit on that board and you come to that board meeting, your other hats or your other jobs, they are set aside. The other part is duty to be obedient. So you want to definitely voice your opinion. That's very important. But let's say you're at a board meeting and there's a decision that maybe not everyone agrees with, but it's the majority. You want to make sure that you back that decision of the board. Nothing is worse than going out into the community and hearing that you have a dysfunctional or a rogue board. That's very important. This past health center, I was in New Mexico. I could tell something was wrong with the board president. And so I talked with my team and I said, there's something going on. And so when I spoke with the board president, he told me that everything was great when they got together as a board, but as soon as they left those doors, there were 3 or 4 board members who, in the parking lot, were not happy with some of the decisions that were made in the board meeting. And so as HRSA consultants, not only do we come in and assess the 19 requirements, we can also provide training and technical assistance. So anonymously, he said, I don't want anyone to know that I told you this. So I was able to provide some type of assistance to kind of address that. So that's very important. You do not want to be doing that outside of your health center. Yes. Yeah. You just said it appropriately. So not going behind the CEO's back. If there's an issue, and I'm not talking about there's an issue where there's some type of grievance. I'm talking about a non-grievance situation. So definitely would be appropriate. I mean, a CEO doesn't want to be blindsided, right? So if you could CC that, CEO and say, hey, I'd like to talk to this individual. Usually at the board meeting. Or I didn't do anything. Oh yeah, step this way. Oh, sorry. Good Lord, I tried to make you guys deaf. So sorry about that. So usually if you're at a board meeting, on the consent agenda, you'll have senior leadership team have their different sections where they can report out. But there's nothing wrong with going to a staff member and saying, hey, how's it going? As long as it's not done, I'm thinking like maliciously, I believe they are. I have seen that. I've had my senior staff. There's nothing wrong with having them there to present. I mean, it's time consuming, so maybe every quarter you call them in or you have the medical director, dental director. So you're welcome. So pretty much the nuts and bolts of membership. So this kind of section, we want to increase board teamwork and effectiveness, the ABCs on how a board should run. And then there really is a correlation between how well a health center is doing in terms of how the board is doing. So that's kind of what we're going to discuss. Board size. There is no golden standard as to the number of board members that you need to have. We know that HRSA says between 9 and 25 members. I've seen 12, 14. It honestly depends on the size and the revenue and the operations of the clinic. They need to represent all segments of the community. What's important is, so let's say you have more than one site and your site that you want to open is 45 minutes away. Do you have a board, an individual that represents that site or that county? So that's kind of what they're looking at. And then they represent all the necessary expertise. So finance, healthcare, social services, patients, I'm trying to think. You know, you could have a pastor perhaps that's on there. So anyone that can represent the community, mayor, any of those types of individuals. Yes, public housing, I think it's, yes, you definitely want to have someone that's on the board that does represent that. And that's where I kind of want to make sure that we get that taken care of. Did you want to talk a little bit?
That's the person requirement.
Mm-hmm. Mm-hmm. Yeah. Thank you for that. And then we have that other nice requirement. So 51% have to be consumers of the health center services. So when the reviewers come in, how do they know that your board are consumers? What they will do, since you're getting a site visit, is pull the billing records of all your board members for the past 2 years. And then what they'll look at is CPT codes and ICD-9 codes. That's something because my function, I'm the admin and governance consultant. So that's what they will look at. So the 99211s, 99214s, those types of, so if a board member comes in and just gets a flu shot or maybe an injection, that is not considered a visit. So you want to make sure it's an actual visit or a trend. It can be a medical or dental visit, which is important. And then if you have a board member that has minor children, they can be considered consumers. So that's very important. And then we know that the non-consumer members, they can't earn more than 10% of their income from the healthcare industry. We already talked about that they have to represent the demographics of the area that they serve. Employees, spouses, or other relatives cannot serve on the board together. I have seen husband and wife. I have seen mother-daughter. I have seen 2 sisters serve on the board. Kind of not best practices. Throwing that out there. So how do you know where to get your board members from? Where do you guys get your board members from? No one? Okay. Well, maybe your board has a nominating committee, and that's where they can, board members will come from. Your senior staff, so maybe your providers, your mid-levels will know a patient perhaps or a client that is committed, that they can tell that they've worked with or served for a number maybe of months. I have found that the best way to get your board members is actually your front staff, which is interesting to me. And the reason I say that is that your front staff are the ones that have daily contact with those patients. And they know which individuals that call perhaps are nice and not so nice. But the front staff, your patient advocates, are definitely, they are the key. I'm thinking the majority of my consumer board members did not come from my providers. It came from my front desk staff. And so that's something that maybe you could do, advertise, which is important as well. You need to have a board recruitment and retention plan, so probably need to look at that. Write that down. Okay, good. And then maybe have a position description for your board. So when you have board members that come on, do they get an orientation? Some people just come on the board because, they need a 3 o'clock social hour so they can get some coffee and lunch once a month. Really, do you really want those board members on there? Not that there's anything wrong with that. To consumers. I'm gonna have to, let me think about that as I'm talking. That's a really good question. Additional training, you may want to look at that, maybe have some type of a certification. I know that NAC offers that board member boot camp. Some primary care associations, in New Mexico, they do some type of board certification that is actual certification. You may want to look at that. Kenny? Yes, Kenny. Mm-hmm. Yeah, so NAC board boot camp. Yeah, that's probably about $1,000, I'm thinking. So it is kind of pricey. Yes, per person, and it's a whole day. I would check with your primary care association, but yeah, it is pretty expensive. So. Mhm. Mhm. Yeah, you know what? Exactly. See, I planted people in the audience, so perfect. These are just some of best practices that I wanted to throw out there that they're not rules, so to speak. See a lot of health centers that have board members that have been on for 15, 20 years. Perhaps not the best practice. These are just some of the samples. So you maybe want to have 3-year terms with staggered rotations, 2 consecutive terms with a 1-year break. Then they can come back on. I think we talked about position descriptions, so the board, orientation, they know what they're doing. Persons serving on committees, but not the full board. So I went to a site that there are individuals serving on the quality improvement committee, but not on the full board. And it was a nurse at the health department, I don't know, someone from the chamber. It just made no sense to me. They weren't on the board. When you have these committees, this is where you're trying to work and improve. You don't want to be airing your dirty laundry or business to other people that are outside of that. So that's definitely something that we would put down as a PIA or performance improvement. Get those people off your committee. Yeah. Mm-hmm. I think you have to be careful with that as well. Like you can have patient advisory committees, and I think that's kind of I'm fine with that. I think my concern is having those that have ulterior motives for sitting on some of these committees that aren't on the board. So, did you have a question? Right. But then the committee is unable to make, the full board has to make policies. So I think that's kind of where the concern lies. Yeah, you can't have that. And sometimes you have a board that monitors the board. Have you ever seen that? And that's when health centers are kind of in trouble, so they have to have someone external monitor the board. So you don't want that. Anyway. And then I think, is it Michelle, you mentioned rules for removing board members contained in your bylaws. So maybe you have board members that have been on that just don't come, that don't participate, and that's where you have the board monitoring themselves, or the board chair that is working to kind of police themselves. All right. Officers, kind of a brief overview of the different officers of the board. You have the chairperson or president. They're the ones that really work a lot with the CEO. They facilitate the board meetings. They can assign other members to committees, and they delegate the tasks. So they really work closely with the CEO. You have the vice president or vice chair. They're the ones that will be the backup person if the chair is away, and you really want them to be abreast of current issues that are happening in case something happens to the chair and they have to sit down or they're sick. The secretary, they're the individuals that keep the minutes of the board. They monitor the attendance. They can send out meeting reminders. So that's important. And then the treasurer is usually the chair of the finance committee. And they want to make sure that, you have if you get more than $500,000, you get your A133 audit. You look at your budget. There's the reports to the board. And they also help with if there's any questions. Sometimes there's some financial questions at the board, and the treasurer can answer that with the CFO. So some different types of committees that I have seen at health centers. You have the basic ones, or the standing ones. So finance, personnel, QIQ, especially with patient-centered healthcare home that's coming, executive committee, and then some ad hoc ones. So maybe you have the CEO search or CEO evaluation, nominating committee, bylaws committee. Those are some different ones. So how do committees work? Really, the committee is supposed to streamline the board meeting. And so what happens is all the work happens in the committee. So all working through issues, and then they're the ones that will make recommendations to the full board. Once again, they have no power to make policy. It's only a full board that can approve policies. And then again, there should be no rubber stamping. So just saying, okay, that sounds great. Let's just approve that. So that's very important. So finance committee. They usually meet monthly, sometimes before the full board or the day of the board. See a lot of individuals that shy away from this committee because they say, well, I don't have a finance background. I don't know about finances. I think you just need to have a desire to learn and to understand. So anyone can sit on the finance committee. They will receive reports from the CFO and will work with the CEO and CFO. And then this is what they will provide to the full board. And I'm sorry. Sure, I'm sorry.
It may be a best practice, but is there a requirement for the person that consumers sit on a finance committee that there's a certain representation on different committees?
No, not that I have seen. Usually you'll want to have every board member sit on something, because sometimes you'll have the same board members that are sitting on the same thing over and over again. So you kind of want to have that, get them out there. Yeah, mix it up. So, and then I just threw some things in here of recommended some board packages or things in the board package. So maybe a profit and loss statement, a balance sheet. Graphs are huge for individuals to make it easier to understand financials. So you maybe want to look at, what are you looking at in terms of new versus established patients, what your payer mix looks like, how is your no-show rate looking these days. So these are just some of the type of stuff you definitely want to have a snapshot. Another visit that I went to at a health center, their board packet was like 200 pages. Could not understand why. And their finance packet it made up over half of their board packet that the board members got. So what we try to do is kind of just give them, you do all your work in the finance committee and then just kind of provide the board kind of with a snapshot to what is going on. You still have all those documents that you keep track of, which is important. So, and that's just kind of maybe a little piece of the pie as well. Maybe you want to include some AR. So how long does it take to get your dollars from Blue Cross Blue Shield Medicaid in your door? Your cash flow. So if something were to happen, how much cash do you have on hand? Maybe you have a lot of revenue that's coming in, or liquidity or equity. But let's say something were to happen. So how many days cash on hand do you have? And then C, what bumps in the road? So maybe implementing EMR is going to be huge. Doing patient-centered healthcare home, going to ICD-10. We just did a conference call with our health centers. That's going to cause a lot of problems going from ICD-9 to ICD-10 with all these denials that could potentially happen. And then HRSA puts out those performance measures, so cost by encounter, cost by patient, those types of things. The Personnel Committee, they essentially will review and update personnel policy. They'll look at job descriptions. They could make recommendations about positions, not the person, which is important. And then at times I've seen the Personnel Committee serve as the grievance committee if there's something that goes against, maybe perhaps there's a complaint against the CEO or something like that. It is all dictated in your bylaws. So, Quality Improvement Committee, that usually is chaired by a clinician with experience. It does not have to be a physician. It can be a mid-level as well. As we mentioned, there's patient-centered healthcare home that's coming out, meaningful use. So these are all things that you would talk about in your QI. Also, maybe you have to do peer reviews, patient satisfaction, your clinical measures. Some of your clinical UDS data can be talked about in here. Also, you can add risk management here. So any sentinel events, things that happen. And then even if you want to throw in credentialing of provider staff before that goes to the full board, you can do that at the QI mini. I want to talk a little bit about board meetings. Minutes need to be kept. FYI, since you're having a site visit, we've seen a lot of board minutes that will say finance committee, minutes approved, all in motion, blah, blah, blah. There's no meat or no detail to the board minutes. What are you approving? And so that's something that is a concern. So we want to at least know what the board is approving. So just saying that the board packet was approved is not really helpful. Yes. And signed, correct. So minutes are very important. You could have your annual meeting if it's open to the public. You can have that up there and open. You definitely want to have an agenda, and I believe you had talked about, I'm sorry, I don't know your name. Nick, nice to meet you. Had talked about, having individuals, maybe your senior staff, go to the board meeting to give a presentation of how your department is doing. Maybe talk about public health, homeless, behavioral, dental. So that as well would be helpful. And then just Robert's Rules of Orders. So pretty much your bylaws is, that is your guide. So if you're out of compliance with your bylaws, you will be out of compliance with HRSA's program requirements. So make sure that your bylaws are up to date. Mm-hmm. Yes, your bylaws are what dictate your health center. Nope, someone else. Mm-hmm. Mm-hmm. And I believe that's program requirement 18. That's one of mine, so that's how I know. So what about outside relationships? So how does the board interact with these three: communities, health center staff, and funding agencies? Definitely you have that community connection. So every member is a spokesperson. And then I want to talk a little bit about community development and fundraising. I think that is definitely the board's responsibility. The CEO is busy running the health center with their staff. But wouldn't it be great, let's say you have a capital campaign or you're trying to raise some funds, wouldn't it be wonderful to say that 100% of the board members have donated money? And they don't need to know it was 50 cents or $1. It's just 100% of the board is committed to your health center. So that's something kind of that I recommend as well. And then maybe fostering some relationships and linkages. Maybe some of your consumer members, Nick, that you talked about are hospital folks, or are on the city council or a state representative. Those are where your connections are, and those board members can foster that connection. How about with the health center staff? The CEO, I think what's hard as a CEO that I had found is where your board tries to micromanage you. So definitely you do not want to have that. And the CEO really maintains control of the daily operations. They are the link between the rest of the health center. And again, you have to have a high level of trust in your health center. Yes, Rudy. Yes, the CEO can delegate that to the COO. Ultimately, the CEO is responsible, but there has to be some type of delegation because you don't want that CEO to have a heart attack because he's stressed out. That's why you have staff to delegate to. Okay, what about outside funding agencies? And these are just some of the areas. You have public housing, homeless, the Bureau of Primary Health Care, maybe your local state government, your insurances. So these are all relationships that your board potentially could have collaborations or can go to for some funding requests. And then I just threw this slide up here just to give you an idea of where you could go for the boards for some assistance. And these are the two documents that I use when I go out, just to kind of give you an idea. This is from, I'm sorry. Oh, sure. This is free. It's from the Bureau of Primary Health Care. You can go online and order it. This one just came out from the National Association of Community Health Centers. I think that's $20. But don't tell her so. I like that one better than the free one. And it just gives a little bit more information. When I head out and do site visits, that's always something that I will leave with them or give them access to, that all board members should have that. So I really do like that. And that one is good as well. You can also talk with your primary care association. Perhaps there's other health centers that can mentor the board, especially there is, it's hard when you're a board member and you don't know if there's anyone else that is doing the same work that you are. So maybe working with other health centers, you can invite them to your annual meeting. There's a number of things that you could do. So, how to build a health center. Yes, Rudy. No, of course. Go ahead. Mhm. Mhm. No, because I think that would be considered like board bias. You can't really, you want to have someone that's vetted into the community, I would assume, that wants to be a part of that. So, Nick? Yeah. Yep. Mhm. Right. Yeah. Yes. And also, is it the CER replaced? Is it the SAM where they have the exclusion list? So. Yes. And the interesting part is because board members also have to sign financial, I think it's disclosure. And there was also something, we just had this discussion, do they need to do background checks? And I think that's something that, I'm trying to think. I think those would be some of the disclosures. I don't know what your thoughts are on that. So, There is none, unfortunately. And I'm trying to think, sometimes there's those PINs or PALs, the policy assistance letters, and no, there is nothing on board members. So. Right. Right. Mm-hmm. Yeah. Mm-hmm. When an individual fills out like a board packet, there should be a section that says like, a disclosure or something. And if they put exactly. Yeah. Yeah. So, but that's really great. I'm gonna go back and look at that. I haven't had that yet. So, how to build a community health center? I don't think there's any gold answer, because if there was, I probably would be rich and retired somewhere with a margarita. But I just wanted to give you a few kind of concepts on how to build a really good health center. Number one, a needs assessment drives everything. That is program requirement number one. So you need to make sure that you have that, write that down. And it can't be more than 3 to 5 years old, so that's very important. So how do you know what services to add if you have never done a needs assessment? How do did a hospital close in your area? Are there providers that aren't taking Medicaid anymore? Is there no dental services in the area? Is public housing an issue? So how would you know if you did not do a needs assessment? And then what are the trends? And then how do you meet those? So now that you know that you have this need, who do you need to help make that happen and to see those patients? Do you need to add providers? Do you need some more space? Do you need some more support staff? And then really to calculate a realistic and balanced budget. So if you're a new health center and you're saying, hey, within the first year I'm going to be making $6 million, yeah, that's not going to happen, trust me. You definitely want to project it, especially when you hire a new provider and you're saying, that doctor is going to see 28 to 30 patients a day starting out of the gate. That is not going to happen. You definitely want to project to realistically what it's going to look like and what it'll be like. And then, are there funds available? Besides HRSA funding, do you have a line item in your city budget or in your state legislature? Do you have, some wonderful funders or that have left something for the health center if they passed away? So those types of different funding streams. Once you have all that, you definitely want to operationalize it. I can't talk today. Do you need mid-levels? Do you need nurse midwives? What do you need to make your needs assessment or your vision happen? How are you going to recruit staff? Are you going to work through the J1 visa, National Health Service Corps? We've had a huge push right now to look at hiring veterans. Do we want to see if there's any veterans out there that need a job? And then how are you going to support your provider? So yes, you want to make them see all these patients, but how are they operating to the level of efficiency or licensure? We always talk about that we want individuals to work to the top of their licensure and not to the top of their ability. How are they going to do that? Do they have enough support staff? Is the 2-to-1 ratio, 2 support staff to 1 provider, correct? We're looking at care teams and teams transitions now at patient-centered healthcare home. So really, how are you going to make that happen? Do you have enough front desk? So I think that's all I have. And we have no more questions. Rudy, yes. Okay. What? Right. Yes, it is a HRSA requirement. So that number one is the law. I think they want to make sure that that's the community that's using those services. So when you have those individuals on your board, they're the ones that are driving the mission and vision. So let's say that they are a consumer and they're saying, we need optometry, so to speak. They're the ones that are essentially saying what services that you need. I'm just trying to think. That's pretty much, I think it's important. They represent the community. Yes.